Almost 6 weeks now since the rollout began. We do know that it started on the 1st of October 2024. Today is the 12th of November 2024. What has the situation been? How are Kenyans, grappling with accessing healthcare? Because we've had concerns from various Kenyans, especially those who are battling chronic illnesses, that they are facing a myriad of challenges in trying to access health services through this particular new scheme. And in fact, some of them have been forced to pay in cash to access services such as chemotherapy, radiotherapy, or dialysis, which cost around 11 to 12,000. Now, what has the government gotten wrong in this particular rollout? And when I talk about the government, of course, that is the Ministry of Health. And what needs to be done to sort out the mess that we are witnessing in the rollout of this particular health scheme? Now, let me begin with you, Honorable Pukose, because you are the chairperson of the National Assembly Departmental Committee on Health. And your committee did give this particular rollout a clean bill of health. Now, almost 6 weeks later, what is your assessment of this particular new scheme and the implementation across the country?
Thank you very much. On 1st of October, the Ministry of Health began implementing the S.H.A, that's the NHIF program on providing universal health care to Kenyans. This program, when you begin any program, it has both challenges and as you implement it. So far, the ministry has been, we went as a committee, we visited some of the facilities. We went to Moi Teaching and Referral. And at the Moi Teaching and Referral, we found that the hospital had actually set up, even at the outside, set up a facility to be able to enroll members into the universal health care, that is NHIF, primary health care, and also a chronic, critical, and emergency fund. Apparently, one of the biggest challenges is that people want to enroll when they are sick, which should not be the case. People should be able to enroll before going to the hospital, because when you enroll, when you go to the hospital, you are trying to enroll and trying to access the services. Mm-hmm. That is the biggest challenge. Even this morning, somebody is sending me a message and asking me that we are not able to access our care in terms of NHIF. And I asked this person whether he's enrolled into the program. The person responds, not yet. Now, you are already at the hospital, you want to access services, and you've not enrolled. So last week, when the CS of Health appeared before the committee, one of the things we asked them is that if they can be able to move and even use our offices at the constituency, the 290 offices within the constituency, the women reps offices at the county, the 47, the senators' offices, and be able to enroll members, not just when you are sick, enroll before when you are healthy, so that when you go now to the hospital, it's not a question of you now enrolling into the program, but it's a question of you now accessing the services.
Honorable Pukose, there are very many other Kenyans who have raised concerns because they're saying they have registered, but still they cannot access health services. In fact, some private facilities do say that there are challenges with the IT system.
So far, some of those challenges have been addressed, because the initial, like you have somebody enrolling at the level 2, the program is, you have a referral system. Mm-hmm. In this referral system, you have to be referred from level 2 or level 3, and that is where the problem has been. But so far, I think those challenges of referral from level 2, level 3 to level 4 or level 5 are being addressed. Mm-hmm. One of the things that happens is that once you arrive at the hospital, then you are being entered into the system. It sends you an OTP number in your phone. So you find that some of the challenges is that maybe you did not register within your phone, or you register, somebody registered you, maybe your relative, your daughter, your son registered you using their phones. So that is where the challenges are. But I think these are things that can be addressed.
Okay, fair enough. Mr. Gibore, let me come to you. There are challenges, and the Honorable Member for Endabes, Honorable Pukose, has alluded to. There are challenges, yes, and some of them are being sorted. Now, the issue of there being challenges, it's a term that we've heard from senior government officials. In fact, President William Ruto said there are challenges, but these challenges are going to be addressed. But now, the concern is, when are they going to be fully addressed? Why were these challenges not, sorted before the rollout of this particular scheme? Because the ministry did say they conducted a pilot program. They must have, noted that there are challenges here and there. Let us just hold on to this scheme before we roll it and ensure that when we roll it, everything will be seamless. Because if there are challenges, people are dying at the end of the day. So if it's a matter of sorting these challenges, it might take time, and people might have, suffered from that.
But let me just address that. These challenges are not, they are system cost. And anybody who has gone to maybe Moi Teaching and Referral, Kenyatta National Hospital, most of these public hospitals has not been turned away because you cannot be entered into the system. Because we've seen, we went to, when we went to Moi Teaching, people even who are coming for renal dialysis and they had not been entered into the system, would take time for them to be entered, and they will still access the services. So it doesn't mean that when the system has any challenges, then you are not going to access services. People will access, and more so, when it even comes to emergency services. Emergency services are accessible to everybody. Okay, fair enough.
So I think these are questions that every Kenyan are asking, because we are talking about people's life. And every time we make a mistake in health, you cost people's life or you push them to complication. And that's what we expected the ministry to have anticipated, so that they prepare properly before any transition. Remember, we had 1 full year for transition. So we ought to have proscanated and projected that indeed this is what we expect and this is how we are going to move on. And we have a tendency of government officers doing everything in the boardroom without involving stakeholders who probably have better idea and support the system so that it is able to transition. It is today, as we speak, we are still sensitizing even service providers on what should happen after the transition. Is that really what should be happening? We are still talking about what should have been done instead of what should we now capitalize on to ensure that we maximize services. Remember, when we were transitioning, we were saying that Kenyans are suffering and are not able to procure medical services because of the cost. When now we pronounce ourselves and transition without putting the mechanism that is supporting such a service delivery, I think then we tend to defeat the same purpose that we want to achieve. Let me point it very clear, that the law anticipates that the government will conduct the main testing, approximate testing activities to identify indigents, people who cannot pay for themselves. Because in any case, they were the main reason why we were shifting, because they were not able to get services under NHIF, so that we can provide services for them. They have not done it to date. So then we do not know how many indigents we have, members, people who are going to depend on government, so that government can pay for their services. You understand? So those are the people that will have seen government transitioning before even pushing everyone coming this side. Let me put it in another term, that we have the pure responsibility that was directed to what government ought to do, which government ought to have done it to actually maybe have trust from the Kenyan, that for us, we as government, what we were supposed to do, we have done it. And some of that such an issue was to allocate enough resources. What was the government projection? Primary healthcare, government projected to start with 50 billion. What did they allocate? 4.2 billion. And they said we don't have enough money. But you tell Kenyan, because we have said we are going to deduct you 2.7%, and even when their pay slip cannot accommodate, they pushed it there. The government, for them, they adjust. Yet they had already projected and told Kenyan that this is what they're going to do. They were to provide 70 billion for emergency critical care and chronic care fund, which is one of the funds that then we ought to have seen that when wameweka pesa, then we have trust that government is intending really to realize its own promises under the S.H.A. Okay. They gave us only 2 billion. Okay. So what government is doing is actually giving us law that on their part they actually bend it, but they push Kenyan to comply. Let government start by complying first. Okay. So that then they do what they are supposed to be doing, then they move to this side. Okay. And I must say it, to date, as we continue talking about what we have done right and what we have not done right, there are Kenyan, even if there is a single Kenyan who is suffering and is struggling to access services, including many of our members who have not been able to access services during this transition period, I think is something that we did not expect, and the government should apologize for it. Okay. What of the pronunciation that the government continue giving? I have seen the government, even the PS, talking about, we are asking, we are now paying more. Why should someone go to pocket to actually topple to procure services? Okay. And the government and the PS says anyone who wants a better term can procure another, and then we are paying more than 3 times what we were earning. We were paying. Let me finish.
Briefly, kindly.
When the first week, when we saw cases in MTRH, what did the CS say? That we are going to refund those who paid from their pocket. Have they refunded anyone? Did they even publish the process of refunding anyone? I have people who have paid from their pocket up to 200,000 to procure even just a certain section. Okay. The government has not refunded anyone. So my issue is, as we moved from NHIF because we did not trust it. How is the government going to ensure that Kenyans are trusting what they are doing in specifically a system that is going to procure services?
Fair enough. I want to engage Honorable Mburu, but before I engage you, sir, let's just listen from Wambui Mitine, and then we get the perspective of what the situation is, and then what you as the county governments are doing, and what is the situation on the ground. A very good morning to you, Wambui Mitine. Thank you very much for joining us.
My name is Wambui Mitine, as you've mentioned, and I'm an advocate. And for me, I'm coming from the legal perspective of S.H.A and the act of the Social Health Insurance Act. And when I listen to Honorable Pukose, I'm wondering, especially on the challenges, what they've done, because when you look at the judgment that was delivered on the 12th of July, that was supposed to halt the SHIF and the S.H.A, the court said that the public participation and sensitization should be done. And was that done? So when you look at, I mean, the way you're saying it's been 6 weeks since the rollout was done, you look at what has been done so far by Parliament and by the government, and it's like it's suddenly an emergency. Yet there's been a whole year of implementation of all these things that are supposed to be done that haven't been done. And compliance was supposed to be done within 120 days of this particular judgment. It was set aside by the Court of Appeal, yes, but these are still things that should have been done and weren't done. And when you go to Mashinani, because I also run Sharia Mashinani, you see that when you go to Mashinani, these people do not know about SHIF and they do not know about S.H.A. And Mheshimiwa is talking about people are enrolling when they are sick and all these things. And when you look at it, ideally, the enrolling should have happened earlier. And when you look at NHIF, for example, NHIF people did it willingly. Anyone would have, I mean, you would have gotten anyone and you're asking them the first thing, do you have NHIF? Hiya, go to NHIF, do this and that. But this new model, there's so much that's going into it, and people have not taken up. And instead of the government telling people what it is, educating, public participation, sensitization. They've not done that. They're just telling people enroll, enroll, enroll. And now when you look at the tariffs and what the benefits that people are supposed to get, vis-a-vis the amount that is being deducted, it's not commensurate. The tariffs, because when you look at the Court of Appeal judgment, it was set aside on the strength that the regulations and the tariffs would make sense, would be equitable. But when you look at what is being offered vis-a-vis what was being offered before by NHIF, and then you look at, again, the deduction that is being done on the payslip, they're not commensurate. And so I'd also like maybe just they tell us, what are they planning, the government, Honorable Pukosa especially, what are they planning to do so that it's equitable? When you tell me that it's 900 per household, it's 2,000 for dental per household, yet all the members of the household are actually remitting this money. Is it that they are going to amend these tariffs? Because again, it's universal health care for all, not just for individuals.
Okay, thank you very much, Ombui. Now, let me engage you, Honorable Mburu, because you are at Mashinani, like Ombui says.
I could respond to what she has raised.
Let me just engage Honorable Mburu, and then I'll give you time to respond. What is the situation on the ground? How are you in Murang'a County, grappling with the rolling out of this particular scheme? And what is the situation literally across the county?
Thank you very much. I want to come to a point where I want to put it across. County governments are the recipient of these regulations, and they are one of the largest stakeholders in issues healthcare. Since we operate all the level 2 hospitals, level 3 hospitals, the level 4 hospitals, all the way to level 5 hospitals, we also entrusted in ensuring that the care is given to the public. And so these regulations and how they are implemented affects the workings of a county government more than any other institution in terms of implementation. I have to come to a point where I have to agree on one sense that the value for ensuring that all public is covered under a universal health care plan is a very noble idea, because we want to see the public get services for health care regardless of their economic means. And it's definitely a noble idea, but its implementation also requires key strategic steps that require the government to be able to take those steps. As a county government of Murang'a, through the leadership of my governor, Dr. Kangata, we have made considerable amounts of progress in this case. Because when we transition from NHIF to Social Health Authority or S.H.A, Social Health Insurance Fund, remember, not only are we transitioning everybody, but also we are transitioning even the special packages that we are offering to the people. One of them in Murang'a was the scheme that we run as a county government called Kangata Care. That in conjunction with NHIF, we were providing and paying for indigents in Murang'a up to 40,000 households, around 160,000 people of Murang'a were being paid for. And once we realized that we need to transition all our people towards SHIV, yesterday we began a 16-day campaign, not only to register those indigents, but also do a mean testing for them so that we also understand how much we are supposed to pay for their behalf in terms so that they can be able to access healthcare.
Let me just interrupt you briefly. You did undertake a pilot program.
Yes. How
many people did you include in that program, approximately?
When we conducted a pilot program to see what it's going to cost us in terms of mean testing. So we did a small survey in every sub-county, and we were looking at the cost of SHIF and how we are going to pay for it. But we also understood that we had a responsibility that we had promised the people of Murang'a, that we are going to pay for their NHIF and their Kangata Care, those who we had enrolled. We had registered 40,000 households, and we are transitioning the entirety of the 40,000 households from NHIF in towards the SHIF so that we can continue covering for them. Yes. Our challenge right now, when it comes, beginning yesterday, we began in every sub-county, in every ward, We are going from ward to ward in a 16-day campaign to ensure that everybody registered at the Kangata Care is registered in SHIF and also does what they are calling mean testing so that we understand how much they are supposed to pay.
Okay.
One issue that is arising, and this is what I would like to engage the chair, National Assembly, the Health Committee on, is in terms of the regulations and what they foresaw in the regulation within mean testing. Because SHIF being a universal health coverage is supposed to be cheaper. And it was marketed to the Mwananchi that is supposed to cost 300 shillings for the lower Mwananchi. When we did the initial survey of the people in Kangata Care, these are people who cannot be able to afford healthcare. They couldn't even pay the 500 shillings. They are the elderly, they are the people, they are the orphans, they are the people, indigent people living with the disabilities. They couldn't pay the 500 shillings. Right now, when we did the initial survey, the amount that they were supposed to pay is not 300 after doing the mean testing. The average person after the initial mean testing jumped from 300 to 600 and even some cases up to 2,000 shillings a month. And this is the question that we are grappling with, because we need to understand, because once you register, there is no way of lowering your mean testing. So if the normal Mwananchi, the one who cannot pay, and even the government had identified as a person that we are supposed to be paid, cannot afford the 300, is not, the mean testing is not getting to 300, then there is an issue that needs to be sorted out when it comes to the issue of targeting and mean testing to provide universal health coverage.
Fair enough. Because of time, I don't want to ask the question that I wanted to ask Honorable Pokose, but I want you to respond to whatever Wambui Mitine did raise, the issues that you wanted to address before Honorable Mburu gave us his views.
Thank you. I just want to make a few clarifications that the Social Health Authority runs 3 funds. It runs the SHIF, which covers for level 4, level 5, and level 6. Then it runs the Primary Health Care Fund, which covers for level 2 and level 3. It also runs the Emergency, Chronic, and Critical Illness Fund, which covers for, once you've exhausted your SHIF, then you, for example, you have a patient who is diabetic, a patient who has renal failure, a patient who has any other chronic illness, hypertension and others, then you can be able now to access that fund. The Emergency, Chronic, and the Critical Care Fund is funded by the national government, similar to the Primary Health Care Fund. George here raised about that the amount that has been allocated is low. That is a start point. We are starting from 2 billion for the emergency, and then primary health care, we are starting at 4 billion. There might have been calculations to such an extent that maybe this is what is required. But and since it is being appropriated by Parliament, we have supplementary budgets that will come in. Once that fund is exhausted, then we can be able, through a supplementary budget, to add some more funds into it. So it should not be just that it is cast in stone for the financial year. This is the amount that has been allocated, and therefore somebody will look at it and say this is too low.
But for the
now
case,
coming to the issue that was raised by Wambui, that it is easier for somebody to initially to be able to enroll into NHIF. That is true, fine, because these are people. This is a fund that has been there for many years, for more than 50 years. But look at it again, that people are only enrolling into NHIF when they were sick. When some, especially those who are doing personal contributions, they'll only enroll into NHIF when they are sick. And once somebody is not sick, then they don't enroll into it. Now, when you look at this other fund, fine, we might not have done very good in terms of public education, sensitization, and that, but we are still pushing it. We are still pushing the ministry, and you see, you are hearing from Muranga what they are doing, even in terms of mean testing. These are challenges that are arising out of it, that you do a mean testing and you find that somebody who was deserving is not being asked to pay 300, but is being asked to pay 600 or even 2,000.
Okay, fair.
So we've asked the ministry.
I want you to hold on to that thought. Let's just take a brief breath and then I'll let you finish up on that, because there's also a concern in regards to the means testing instrument. And the reason as to why I was asking about the number is that your committee, in the final session before the rollout, Dr. Patrick Amoth did say they did conduct a pilot program and they only involved 2,000 people across the country. The number is a bit questionable.
And we didn't agree with that number.
Yes.
As a committee, we told him that number was too small.
Exactly. I will come
for
to
sampling purposes, and they should be able to do a better job.
I'll come to that. Let's just take a brief breath and then we'll come back with that particular conversation.